Good evening, everybody, and welcome to the December 10th Windsor Regional Hospital Open Board meeting. We will call the meeting to order. It is 5:03 p.m. Do I have any declarations of conflict of interest? Seeing none, great, thank you. Can I get a motion to approve the previous minutes? I see Paul Lachance, seconded by Michael Lavoie. Questions or comments with regards to those minutes? Seeing none, all in favor? Great, thank you so much. First up, we have CEO David Mouche. Unmute.
I'm fighting with you there. Thank you,
Yeah,
Mr.
sorry about that.
Thank you, Mr. Chair. Welcome, everybody, to the December board meeting. It's been an interesting journey, as we all know, from the start of COVID through to today, and especially over the most recent period of time. Unfortunately, all of the predictions with respect to a second or subsequent wave are coming true as the weather cools down, as people go inside, and unfortunately, you add to the issues, the COVID, what they call COVID fatigue, where people are tired, are frustrated, and are trying to continue to interact with each other in the community. And then at the same time, the economy is trying to continue to get hold and continue along. And heard about this over the last couple of weeks. Is this wave or secondary wave is different from what we went through back early on in March and April. If you recall, in March and April, everything was pretty much shut down. Everybody went inside. As a result, when we had cases early on, it was a lot easier to determine who the contact was of someone who's positive, because there was such a definitive amount of places that were open, or be it a long-term care retirement home. Even as we got into the agri-food worker situation, it became very focused in the sense of public health would announce so many positives in a given day, and most of the time they were able to say with 90% certainty they all have contacts. And that created a very focused world, in the sense that we were able to definitively know where people got COVID from and try to deal with that situation. Fast forward to today, what we've seen with respect to the COVID numbers is that there isn't this definitive contact tracing opportunity. Even from our own staff point of view, who have tested positive with COVID, it's very difficult for our staff to, for us to determine with our staff who their contacts were. Did they get it from another employee? Did they get it in a hospital? Did they get it in the community and came in? With the 5,000 approximate staff we have working at the facility, it's getting very difficult, especially as a result of the community spread that's taking place. So as we move from orange to red in the rankings of the color chart for the province, and as things started to restrict, every 2 times every week, we have a meeting with the leadership of the medical leadership of all of Erie St. Clair, which includes all of the hospitals from here to London. And at those meetings, we discuss in various what we call tables, be it operations, HR, communications. We discuss status, and also they report on action items they've had at their various table or committee meetings, which are made up of representatives of all of Erie St. Clair, and information is fed up to be shared to give it a status report and action items they're working on or they've implemented. Part of that is having public health attend from the three regions in Erie St. Clair, and they provide an update on how things are going. When we moved from orange to red, we had a discussion regarding how long are we going to be in red, meaning the clinical folks, non-clinical folks on the calls were concerned about we're heading, or we have kind of gray numbers that we moved to red, but we were very concerned on how things were playing out. So generally the rule of thumb, even though it's a new color coding, is that usually you wait 2 weeks to see how your data goes after you move to another category to see if those changes took effect. And if they didn't, then you would move into the next category. So our concern at the time was that 2 weeks probably was too long, but we recognized the theory behind that. So sure enough, we stayed in red this past week. And our concern, of course, is it looks like we're heading into a gray area, and we'll find out definitively tomorrow what that is. And the concern we articulated is that usually you get announced your new category on Friday, but it doesn't take effect till 12:01 a.m. on Monday. The issue is having right now at this time of the year, 2 days notice to go from red to gray, which is a pretty substantial difference between what is open and what is closed, is not good. That unfortunately, human nature being what it is, 2 weeks in advance of Christmas, the need to recognize that we're going to be shut down for Christmas and New Year's Eve, effective Friday for Monday, if that's what happens. Having 2 days of what I call super spreader events is not good. And we talked about this before, even before some of the data, it was creeping up, but now it's to the point of if there is a definition of gray, we're in it. So I'm going to pass it over to Karen Riddell just to give a status update on where we sit with respect to overall census, overall numbers. And the reason I want to do that is the numbers are changing that rapidly right now. So Karen Riddell, would you mind, Anthony, unmuting her? And can you find her? Oh, I'm the co-host now too, so. Oops. Okay, who's doing it? Okay, there you go, Karen.
Yeah. I unmuted myself and then you muted me right away. So, so the numbers have been very dynamic. Honestly, it actually took me a while to get current state because we've been getting new positive cases in all day and new results. So right now we're sitting at 90% occupancy when you look at our vibe, but we have over 47 beds blocked due to COVID, either confirmed or rule out. We have 28 confirmed positive COVIDs in-house. 9 of those are in the ICU, and we have another 40 highly suspect cases. So sitting right now from a critical care perspective, we have 1 ICU bed left. We've bed spaced already into our CCU, and we have 1 ICU patient bed spaced in the PACU. So our last 4 beds are sitting in the CCU right now. We've already dipped into our provincial ventilator stockpile as of yesterday, which means that we've used our usual hospital allotment of ventilators, and we do house the provincial stockpile on site, so had to dip into that to ensure that we had adequate ventilators on hand. And then we just received a call from one of our partner hospitals that they have an ICU case for us as well that we're potentially receiving. So just looking at that. And then most telling, I think, and certainly very sadly, we've experienced a number of deaths over the last 3 days. So far in the last 3 days, we've had 6 deaths related to COVID-19. So that's unfortunately where we're at. increasing very rapidly from a hospital perspective. And as we, I think, all know, that's a trailing indicator. It's an indicator of what has been going on in the community a couple, 3 weeks ago, and people are sick enough now to be in the hospital. So it's very concerning.
Thanks, Karen. So the concern we've been echoing and commenting about is the status we're in now, but also the status we're going to be in approximately 10 to 14 days from now, because of the most recent positive results, primarily 2 days ago coming through our assessment center alone. We made up over 100 of those positive cases being tested in our assessment center. And then the numbers that'll be announced tomorrow. I mean, we don't have the final numbers because public health has them, but our assessment center numbers are high with respect to positives. So I don't see that decreasing, if anything, increasing. And then also we have to recognize that we're seeing at the assessment center, we're swabbing, of course, symptomatic individuals or contacts, but there's most likely still more individuals in the community who are positive that are not being swabbed for whatever reason. And as a result, these numbers we're seeing probably are on the lower end of how many positives we actually have in our community at any given time because of that phenomenon. So as indicated, we have 9 in the ICU with COVID. Our highest number ever in the ICU is 13 with COVID. Our highest number ever of inpatients was 27. As indicated, it's now 28. And then coupled with that is the very tragic deaths just over the last couple, 3 days of the 6 deaths. So we are pretty much full with respect to inpatient beds, with respect to ICU capacity. So we're going to be working as a team over the next 24, 48 hours to examine our pandemic plan and determine what steps we have to make moving forward as an organization as a result of these rapidly increasing numbers. So before I go on to the next item, I don't know if the board has any questions on that item.
We see a question from Pam. Pam, I'm going to unmute you now. You're good, Pam.
Okay, can you hear me? All right. What I don't understand is you would think with this second wave, after we're all doing social distancing and masking and hand hygiene, that it wouldn't be as bad as the first one when we didn't do anything. I'm not medical and I don't understand why this wave seems to be heading towards being worse than the first wave when we didn't do any of those precautionary methods.
Well, I'll go first, then I'll pass it off to Dr. Saad. So I think the difference between this wave and the first wave, again, the first wave, a lot of things were closed down. A lot of people were inside in their homes, or it was springtime. So you were starting to get outside, which clearly is a massive difference with respect to the spread of COVID being indoors versus outdoors. And people, even at the start, even though, yes, they weren't masking and yes, maybe social distancing wasn't as pronounced, we still had the opportunity to be outside. And a lot of people were not going to work, were not going to larger settings and interacting with other individuals. So we had that issue. Now, as everyone had said was going to happen, is happening, not only here, but across the province, across North America and other areas too, is now that the weather is colder, people are going inside, but at the same time, we have schools up and running, or we did until Monday. We had schools up and running. We had, people going to work, interacting, then coming back and spending time with their families. So indoors. So it is, we're seeing that. I don't know, Dr. Saad, if you wanted to add something.
So the different variable then is being indoors.
It's a big one. I'll let Dr. Saad speak to that.
Yeah, Pam, David, I agree with everything that you said. I think the biggest issue with why we're having a worse second wave is the fact that schools were open. Children going to schools, the outbreaks that we're seeing, obviously they can't keep their masks on all day and then they bring it back home. And you couple that with the colder weather, people starting to congregate inside, and COVID fatigue, where people were relaxing some of their public health measures. It was a perfect storm, and that's part of the main reason why second waves are always bigger than the first waves.
Yeah, and we were seeing when we went out to on site to help swab the schools, a lot of the families, interesting dynamic is larger families, multiple children, but multiple children at different schools. It wasn't all the one school we were at. They had different age groups at different schools in, you know, the 3 systems, I assume, depending on which programs they were going. So you had that dynamic that if you had one positive in the family, it's spread out. Then in addition to that is you have to remember the teachers of those children, their children go to different schools as well. So it starts, those tentacles start with respect to the spread. So when you have large outbreaks like we had in our system, and I would imagine that led to our public health officer making the announcement he made, especially in light of today's positives, it's because of that, is the tentacles of that going through the rest of our region. And you know, our staff is just, you know, we're a town inside of a big city, Windsor Regional Hospital. So our staff is not immune to that. So their children, we had staff that their children were positive, and the staff, of course, live with them and had to stay home. So, you know, just in those numbers, Pam, as we went, keeps from the start of COVID, March, until basically the middle of November, we had 14 staff out of 5,000 test positive for COVID, which is, I think, shockingly low, but it was great. And then from the middle of November to now, that number's more than doubled. We're into 35, 36 staff testing positive for COVID in a 3-week period, as compared to, it was months where it was that amount. So again, it's rather dramatic. The one thing we do know is PPE works, that even if staff get it, not spreading it to patients and vice versa, it works. So that's what we're working through. So I don't know if that helps, Pam, answer your question.
Pam, I muted you. Sorry about that. Any other questions for David with regards to this subject? I know there's a few more items on his list. So just from my perspective, there are people watching on YouTube, so just be kind to one another. Nobody wanted to get COVID. And, you know, just really the whole thing is be kind to each other. If somebody had COVID, they didn't want to get it. Just be responsible, wash your hands, use your masks, you know, social distance, and follow the protocols, and we'll all get through this together.
Okay. Let me go on to the next item, Mr. Chair. Okay. So the next item I want to talk about is vaccines. So what we've all heard is the start of the vaccine starting to roll out. Even in Ontario, there's 2 hospitals in Ottawa and in Toronto that are doing, quote, a dry run of the vaccinations of high-risk individuals. And those lessons will be shared with the rest of us. So as it stands right now, Canada, the first vaccine to be approved is from Pfizer. And Canada is to receive approximately 249,000 doses of the vaccine. And since every individual must take 2 doses, that would satisfy approximately, 125,000 people. Ontario is supposed to get 85,000 of those first doses, and those should be arriving, as I stated, very shortly, and some might have arrived already to the 2 Ontario hospitals. If you do it proportionally, Windsor-Essex, based upon population, Windsor-Essex should get approximately 2,500 total doses. Again, that would support 1,250 individuals to get 2 courses of the vaccine. Now we're being told it's going to be distributed maybe slightly differently, and it's going to be distributed more so to areas in red or gray, but we'll leave that to be seen. Both Pfizer and Moderna, because of the type of vaccine, it's not a typical vaccine, and I'll in a few minutes hand it off to Dr. Saad to explain the difference between these vaccines and a traditional, say, influenza vaccine that we're used to. Is both Pfizer and Moderna have to be kept at ultra frozen temperatures, Pfizer at -80, Moderna at -25. So we have 3 freezers that can hold Pfizer vaccines at -80. They're already in place, they're plugged in, ready to roll. They can house 400,000 doses at any given time. The chances of us ever having 1.2 million doses of the Pfizer vaccine in our freezers are what one would call slim to none. So it'd be a good problem to have, let me put it that way, but we're never going to get there. So as a result, they're very strict with respect to the distribution of the vaccine, Pfizer is. And that has a lot to do with risk management and ensuring that the efficacy of their vaccine stays at what's been testing at 95% once you get the 2 doses, has been showing to be 95% effective. The more it moves, or the more chances of it being taken out of the 80 degrees, thawing, and then individuals leaving it out for too long and or trying to put it back in, will reduce the efficacy of that vaccine and create problems. And they want to make sure, especially in the first allotment to everybody, that we follow very strict requirements with respect to the acceptance of the vaccine and the actual vaccination of individuals. So Ontario government did create a grouping of priority individuals to get the vaccine, and pretty much there's 4. It's retirement home, long-term care home residents and employees, hospital employees. Third is Indigenous populations. And number 4 are elderly individuals with chronic healthcare issues. They did not create a hierarchy of that group, meaning it's a block group of people. So when we get 2,500 vaccines, say, maybe we'll get more, or doses of the vaccine. It's the way it's structured currently is our public health office, say it's for Windsor-Essex, will have to determine the hierarchy of that priority group to determine who in that priority group gets the vaccine. So for instance, again, there's far more than 1,500 or 1,250 people in any one of those priority groups. And as a result, a determination will be made on within those groups, what's the hierarchy. And there's some ethical frameworks being prepared provincially and also locally to do that. So that's within public health's domain. That is not within the hospital's responsibility. Our responsibility as Windsor Regional Hospital will be to accept the vaccine, to store it safely, and then to help vaccinate individuals, or actually do the vaccination of individuals. The issue becomes when Pfizer sends you the vaccine, from what we've learned is that they've allowed 4 moves, which is the movement of the vaccine, say from Germany to arguably Kalamazoo, from Kalamazoo, Michigan to Windsor Regional Hospital is 2 moves. If there's other moves in between, we might run out of moves by the time we get it. And the consideration is, once we receive it, what flexibility we will have, if any, to move it arguably further than our parking lot, let alone somewhere else. So those are the issues we're trying to sort out. And we have to provide Pfizer with an actual address, which we have, for the acceptance of the vaccines. So it's very strict, very focused, but very limited. Is we are not going to be seeing more of this vaccine until probably 2021. And in the Toronto Star today, they had a very good article that I shared with all of you, a link to it, which talked about the fact that I think it's in March of next year, they're hoping to have about 8% of our population in Canada with access to the vaccine, and not getting 100% eligible for vaccination until September of 2021. So it's going to be a slow rollout of the vaccines, and this is just Pfizer. But I was going to share a chart with you. I'll share it real quick. I'll just show you. The one thing Canada has done, and done a great job with, is the number of vaccines Canada has purchased is rather substantial as compared to any other nation across the world, per capita basis. And these are old numbers. Canada has done even better. So what basically Canada has done is we have purchased as a nation over 400 million vaccines for, of course, 37 million Canadian residents. So doses, sorry. So even if you divide it in half, we have quite a substantial doses per capita as compared to any other country, which you can see from this list. The issue becomes, what did we buy and when will it be available? As stated, Pfizer and Moderna are the first 2. And when I did this chart, Canada had purchased 20 million of the Pfizer, which is good enough for 10 million people. But they also just did an option for another 60 million of the Pfizer vaccine. So what Canada did was double down on Pfizer and has purchased, in effect, enough Pfizer to do 2 doses for every single Canadian resident, if we get the Pfizer vaccine. And then on top of it, we'll get Moderna, and then Janssen, and the rest. So when you add up the math here, it's over 400 million doses of vaccines that Canada has purchased. And again, per capita, it's one of the highest. So I'll hand it over to Dr. Saad just to give some background with respect to the vaccine itself, and why, people ask, why does it need -80 and -30, and how does it technically work?
Thanks, David. I'll do my best. Again, with vaccines, over time, we have different ways to deliver a vaccine to people for them to create an immune response. The whole point is to try to expose you to something that a virus or bacteria has, so that your body can build up an immunity to it. So when you are presented with the real infection in real life, your body's ready for it, it fights it off right away, and then you don't become infected. Most of the time in the past, what they used to do is take a virus, grind it up. So basically you're destroying it. It can't really infect you. And then they give you that material into your body. Your body recognizes certain proteins from it, and then it builds up an immune response. So the next time you're exposed to the actual virus, it will you'll fight it off very quickly. With Pfizer and Moderna, these are new technologies. In fact, these are the first ever approved what we call mRNA viruses. So what they do is they deliver genetic material to the person. your body then creates the protein from within your own cells that mimics a protein on the COVID virus. It mimics what's called the spike protein. So then your body then builds up an immune response to it because it recognizes that the spike protein shouldn't be in your body. And you deliver a first dose. As with most vaccines, and just like any other allergic type reaction, you need a second dose for your body to become stronger at it. Think of it like an allergic reaction to bee stings. The first time you get stung by a bee, you won't get an anaphylactic reaction. Your body gets primed for it, gets ready for it. The next time you get stung by a bee, you have a massive reaction, and that's when the danger really happens. So similar to vaccines, the first dose goes in, tries to trigger an immune response. The second one builds it up even more. And then by the time you're exposed to the real virus, your body's ready for it. It fights it off and it doesn't give you an infection. Some of the compounds that are used in these things have to be molecularly stable, which is why the Pfizer vaccine has to be stored at -80, which is quite significant. And one of the only viruses that a vaccine that requires that. The AstraZeneca one is a completely different type of vaccine where they deliver a virus, and inside the virus, there's the spike protein that will build up your immune system, but the virus doesn't cause infection in humans. It's from chimpanzees. So there's different technologies. I think it's a safe bet to say that a lot of this is based on science that's been around for a long time. We expect the vaccines to be safe, and they do require at least 2 doses, although you can get immunity from 1 dose. But the point is, of course, that this happened very rapidly, and people will say, well, how did you develop a vaccine within less than a year? Is it going to be safe? The answer is yes, even though the vaccine happened very quickly and we haven't seen these types of vaccines in a while, the science and the data that they're based on are decades and generations old. So there's going to be a lot of hesitancy for people to take the vaccine. But as David mentioned, there is sort of a hierarchy of who should get it first. And then we'll start to see what kind of reactions people are having, which are not uncommon, as we all know, because we've all been vaccinated against many other infectious diseases in the past. I'm happy to take any questions if anybody really wants to get into the nitty-gritty of the science of the vaccines.
Looking for questions. All right, seeing none. Great. Back to David.
By the way, was that clear, David? Unlike yesterday where you thought it was clear, but you were sarcastic.
Oh, you were clear. What Dr. Saad's talking about is we had a town hall last night with the staff on Zoom, and he started explaining this, and it was a complicated question, and he gave, I thought, a good answer, but there are some things that they're not clear answers to. So you got to go, well, it could be this, it could be that, it could be this, it could be that. And I was like trying to follow that, going, oh, all right, it's, but he gave a great answer. It's sometimes we don't know with some, the question is, how long is immunity going to last once you get the vaccine? We don't know. We're going to find out. But technically right now we don't know. So far, I think Moderna or Pfizer, one of the two, announced that they were still seeing antibodies 3 months post the vaccine. So that's good. So at least we got, hopefully 3 months. So, and, in a weird way, that's probably why a good thing is Canada bought so many doses that if we do have to take it more often, we're going to have a selection of vaccines possibly to pick from to make that happen. So Canada as a country clearly has gone way out there with respect to its purchases as compared to other countries for its population. So you have to give them credit for that. The issue again is distribution. But the big message on vaccines, it's going to take time. This is not something that's going to happen overnight. This is going to take months. So the problem is, while we're waiting for the vaccine and for people to get vaccinated for it to take effect, is what are we doing operationally? And technically it's only December the 10th. And we have a long winter ahead of us, a very long winter ahead of us. If this is what we're seeing on December 10th, it's a struggle. In my report, I'll just finish it. I'll finish it on a good note, is pretty much influenza is non-existent. And you'll see in my report that the number of influenza cases is pretty much zero, very low. And that's not for a lack of testing for influenza. The testing for influenza is even higher than traditionally it is in a given season, and the numbers are dramatically lower, which is exactly, I mean, I think we talked about this back in June when we were seeing the numbers from Australia and their impact of influenza back then. We were reporting on this, is that if we continue with the protective measures like we have, also have a good vaccination season for flu vaccines, we should be doing okay. And sure enough, so that's good work. Last point is just the PCR machine, our own. We've done our own validation. We have to submit that to a provincial agency. They're reviewing it. And I'm hoping rather shortly, we will have approval to do our own PCR testing on site. Again, we have a limited amount of testing kits to use, but hopefully within the next week we will, because as numbers increase, it won't change the way we care for people, but it will give quicker results, especially for our inpatients. We will still be sending results for assessment center individuals to London like we do now. That will not change until we get far greater test kits. And again, that's just a national issue with respect to the number of test kits we can get with respect to that. So, Mr. Chair, that's my my report.
Great, thank you. Do we have any other questions or comments for David or Dr. Saad? Okay, great, thank you. Next up, we have the Schulich report from Dr. Jacobs. Oh, and I will unmute you.
Is working okay?
Perfect.
Thank you. So I guess more somber news to bring to the board meeting, and apologies for that. And so maybe I'll start with a quick update of what's happening in London at University Hospital, because it does have implications on what we're doing here locally. So it's not news to any of you that there's a very large outbreak at University Hospital right now that's affected multiple floors and multiple patients and staff. I think at last count I saw 73 patients have been infected by the outbreak on the wards there, and 71 staff members. And I believe it's 15 deaths have been attributed to the outbreak as well. So very dramatic numbers. And because of that, University Hospital has effectively been shut down as a teaching site for medical students since this outbreak really came out of control. That's one of the two main teaching sites in London. And so because of that, many students were displaced from their learning opportunities and then sort of pushed out into other areas, including Windsor, where we accepted a number of students to try to keep things moving. With the outbreak that we've had here on 7 at Olette, that sort of, even though it was not one that was ever out of control per se, the concern in London was that if you worked on 7, were you then now bringing more COVID back from an outbreak site to their hospital? And so as a consequence, if you were in Windsor working at Olette Hospital and you ever stepped foot on 7, you were then also banned from working in London on any site until you had a 14-day period of not taking care of patients. And so what that really did was probably put a big dagger into many fourth-year medical students who were trying very close to get to graduation and not lose a year of our own workforce that we're putting into future residents and then doctors. It looks like we've found plan Bs for everyone and it's going to work out okay, but it has been a very challenging couple of weeks in trying to find opportunities that are going to meet their curricular requirements, get them ready for graduation, and at the same time allow them to get enough experience in their eventual specialties, which would allow them to be successful in the match, which is coming up this spring. So it has been a very challenging period for medical education across the school. There's also implications for postgraduate training as well. Because of what's happening at University Hospital, many of the residents who would typically come to Windsor have also, some of them have been pulled back to support services which can't run right now because the residents who were at UH have now sort of been quarantined within that department as well. We are still able to run most of our key services. We are able to arrange all of our key services, but it is a bit more challenging with respect to the person power that we need to do it all. So it will be a period of significant stress at the same time where patient loads are obviously higher. So those are things that we're working through, obviously, with wonderful support from everyone here. So thank you very much for that. There is good news in that, as we were hearing, this will eventually end, hopefully sooner than later, but it will eventually end. And as that happens, we do look ahead to what we can do at our school and at our campus. And I think I brought up at this level about a year ago plans that we have with respect to internationalization at Schulich and specifically at the Windsor campus. Once things come to a point where we can, start to plan again on international travel, and a border at Windsor, Detroit is very exciting. From what I'm trying to do is that we are hoping to increase the enrollment at the Windsor campus with supernumerary positions of American students who would study in Windsor as well. That's something that our dean has endorsed, and really now it's a question of timing. And obviously you don't start something like this right now, but once things do settle down, that would be a plan that we're looking forward to. And that will obviously, with the relationship that we have here with the school and Windsor Regional Hospital, it'll be a big part of that as well. That'll be great for both learning opportunities, but also potentially for research opportunities as well, because as we open up those relationships with American learners, we also open up relationships with the American universities and hospital partners who can also help build some of the research infrastructure we're looking to try to do in this area. So it is a very exciting possibility. And the last thing in the report that I enclosed is a list of students who have won awards. I just draw them to your attention in the report, and I will send them all your congratulations as well. So thank you all very much for the time. Back to you, boss.
Great, thanks, Dr. Jacobs. Any other questions or comments, or does anybody have questions or comments for Dr. Jacobs? Seeing none. Well, great job, Dr. Jacobs. Thanks. Tremendous lift by your whole staff right now. So keep up the good work. Next up, we have the financial presentation and treasurer's report. Penny Allen. Penny, you just have to.
There we go.
There you
Got
go.
it.
Perfect.
Yeah.
Thank you.
Yeah. Okay. The first slide here, I'll make some comments on every one of the slides. This is the hospital operations as of October 31st. The year-to-date surplus for the hospital operations is $2,132,000. Revenue is $13.5 million favorable year-to-date. Total expenses are $11.3 million unfavorable, and the largest variance is in salaries and wages. And the COVID-19 unfunded expenses and revenues summarized at the bottom of the statement at $15.7 million. And then the bottom line here basically is that the surplus after the net building amortization. Amortization means is another word for depreciation, is $865,000. So that is the first slide. Second slide is the COVID expenses and revenue that are funded and unfunded. And as the breakdown, the largest component is the pandemic pay, 100% funded, and makes up to 87% of the year-to-date salary and wage deficit. To date, we have received funding for COVID-19 operating expenses from April to July in the amount of $15.6 million, $7 million for the pandemic pay, and $8.6 for the extraordinary operating expenses. Unfunded COVID expenses for August to October were $7.9 million. The volume-based revenues are $4.6 million below budgeted volumes to date, and those include quality-based procedures, neuroservices, and wait time. And then patient services revenue shortfall of 3.6 million are mainly attributable to diagnostic revenues that have not been very high and accommodations revenues. Next item is the year-to-date revenue. Base and one-time funding is 13 million favorable to date. That includes the following items. 13.4 quality-based revenue. The elective surgery cancellations in April and May were lower than planned volumes by 8,573 cases. Volumes are gradually ramping up. I say that now after having said to David, heard from David and Dr. Sad that maybe they won't be ramping quite so quickly. But anyhow, volumes are gradually ramping up, but cases are taking longer due to the infection prevention and control requirements and impacts for the operating room turnaround times. So they can't do as many cases because they take longer, basically. 1.2 million unearned revenue for neuro, cardiac, and wait time combined. So one-time funding is 16 million favorable to date and includes pandemic pay, $7 million, and COVID operating expenses, 8.6 million. So that's good so far. And then drug reimbursement is favorable by 1.8 million. However, these are offset by the increased drug expenses. So yeah, we get more revenue, but it's because we also have more expenses. So that is the revenue. And then we have the expenses. We have salary and wages are unfavorable to 8.1 million. 1.5, oh, wait a minute here, let's see. But this includes 7 million of the pandemic pay. So yeah, and we got 100% revenue funding for that. It's basically the pandemic expense is pay is 87% of the variance. And then there's isolation, sick, and training costs for COVID as well. 1.9 million paid to the COVID helpers. Net patient services revenue and med fees are 1.8 million unfavorable to date, unchanged from the last month. So med surg supplies are favorable, especially in the peri-operative program to date. This variance has been decreasing each month as surgeries and the surgical backlog are being addressed. Again, I think that might change, having heard David. Incremental spending on personal protective equipment to date is 2.3 million based on the comparison of the per case cost in fiscal 2019-20 to the current rate. The average PPE cost last fiscal year per inpatient day was $51.52. This year, it's $78 per inpatient day. So there's a lot more PPE that needs to be paid for and higher and ordered. Next one is drugs. Chemo and renal drug variants are fully funded. Retail pharmacy net revenue is favorable, and drugs are under budget in the clinical areas as this is volumes related, because we had a lot of the surgeries and that they couldn't do during COVID starting in March. Other supplies are slightly favorable. Increased spending in minor equipment and one-time setup for the field hospital at St. Clair incurred at the start of the fiscal year and are offset by savings in utilities. And that savings in utilities was supposed to expire at the end of October, but it has now been, can't remember when, I think it was about April that it was going to expire. We're going to get it longer. That's the main thing, which is good. And then equipment and rental lease over budget due to rentals in the early fiscal year to ensure the capacity in earlier months and was favorable in the month. That is the one, again, I think in St. Clair College there, the sports specs. Now we have lengths of stay, slightly below target at MET and above at OLAT. Mental health programs, Maryvale and Olette campus. Psychiatry had been trending higher in the fiscal year, but both were below target in the month of October. Patient volume. Graph compares the year-over-year volumes to October and the difference. All are trailing behind the target except for community visits, as this includes the 49,685 COVID-19 assessment center visits. That is a lot of assessing, let's put it that way. Whoa. Okay, then I think that's one more, sick time and overtime. Compared to the previous month, all are trending worse except for sick time at Met, which is slightly better than the previous month by 0.10%. Full-time equivalents are favorable at both campuses for normal operations. Full-time equivalents associated with COVID to date are 117.2 for the assessment centers, staff and visitor screening, and the field hospital. So, and then the, just a second here. I have my financial report, which is really just a summary of all that's on the slides. And the final number that is positive is 865,000. It's after, it's the net surplus after the building amortization. So that's 865,000 so far this year, which is pretty good, I have to say. You know, we really made some steps ahead. So I'll now make a motion, if I may, that the financial report as presented on the December 10th, 2020 board meeting be accepted.
A seconder.
Yeah.
Sorry, Arvind, thank you.
Okay.
And then questions or comments for Penny or Mark?
Mm-hmm.
Seeing none, great. Thanks for that report, Penny.
Okay. I think the next one's mine too, isn't it?
Yes.
Yes. So the actual information from the November 30th Finance Audit and Resource Committee it is in this report. So I'll make a motion that the report from the November 30th, 2020 Finance Audit and Resources Committee meeting be accepted.
All right, perfect. Thank you. Can I get a seconder? I think I see Genevieve. Thank you, Genevieve. I appreciate that. Questions or comments? Seeing none, all in favor? Wonderful. Thank you so much. All right, and then we have correspondence and printed material there for your information. We also have, let's see what else we have. All right, we have the Windsor City Council resolution. That was tab H, again, FYI. Then we're moving on. Any questions or comments, additional questions or comments from the board? Nope, great, thank you so much. The date of our next meeting is January 7th, 2021. We will all be on Zoom again, so dress your best. I'm hoping my beard fills out a little bit more before then. Everybody have a safe and happy holiday. Please remember, do your part. And then can I get a motion to adjourn? I see Patty France and Paul LaChance seconding. All in favor? Thank you so much, everybody. We will be heading into our in-camera session at exactly 6:20. You can log in early. If you just be logged in 5 minutes early, we can just chat like friends. So don't wait exactly till 6:20. We can log in early. Okay, thanks everybody. Have a good weekend. Happy Hanukkah to everybody. I think it started today. So again, have